everyone. Myself Pallavi BN of second year MSc Nursing student of Kidwai College of Nursing. Here I am presenting a video on central venous catheter care. It is the most important aspect for nurses to know about the central venous catheter care in order to prevent the bloodstream infections. Central venous catheter is a placement of indwelling catheter into a large vein leading to a blood vessels for a long-term use. Central venous catheterization is commonly used in emergency IV access when peripheral veins are not accessed. If for the monitoring central venous pressure during major surgery after severe blood loss, and also in case of cancer patients for administering chemotherapy drugs for long duration of treatment. So let us have a small introduction on central venous catheterization and its care. Central line, also known as central venous catheter or CVCs, are commonly used for IV medication, take frequent blood sample, or receiving parenteral nutrition for a long period of life. A central catheter contains a thin flexible tube that is carefully inserted into the blood vessels, allowing the patient to receive long-term treatment for cancer and pain management. There are several types of central catheters. You may have peripherally inserted central catheter or PICC line, a tunneled catheter, and an implanted port. In the tunneled catheter and the PICC line system, the tube stands outside your body. To avoid any chance of infection or complication, proper care of central line is extremely important. In this video, you learn how to change dressing and cap and how to flush the lumen. Anatomy and physiology of blood vessels. That is, how they look and what they do. Here we see three major types of blood vessels. Arteries that carry blood away from the heart. The veins that carry blood towards the heart. And the capillaries that acts as a chain has a station between the veins and the arteries. And the arterioles are the mini arteries that branch out into capillaries. It transports blood from arteries to the capillaries. Venules are the smallest vein component that suck blood back out of the capillaries, emerge out into the large vein for return to the heart. Here we have a living group called as capillary bed, which acts as a exchanging nutrients and the gases, where the exchange of oxygen and carbon dioxide takes place. Your capillary beds also regulate blood pressure and plays a role in thermoregulation. If the central line catheterization is done, the vein selection is performed according to the individual patient's anatomical structure, type and purpose of catheter and the vessels used. The main common vessels used for insertion of central line are right and left internal jugular vein and also external jugular vein, right and left subclavian vein, femoral vein and peripheral veins like basalic and cephalic vein. Central venous access devices. There are several types of central venous access devices. They are non-tunneled central catheters, tunneled central catheters, peripherally inserted central catheters are also called PICC line and implanted port. Peripherally inserted central catheters or PICC line is a catheter inserted into a vein in the arm via basalic or cephalic vein rather than neck or chest. The tip of the catheter line positioned in the superior vena cava. Non-tunneled catheters is typically inserted into the neck, chest or groin using internal jugular or subclavian vein. Here the tube stands outside the body. Tunneled catheters will be inserted invasively to help secure it for long time. Here the tube is brought under the skin and the catheter end portion is exposed and it requires daily to weekly maintenance. Implanted port, also called as porta cath, is attached to the reservoir The entire catheter and the reservoir are placed surgically under the skin, allowing the patient to shower and bath without restriction. To access the central catheter, the skin is pierced with a non-core needle and it can be kept in place for 5 to 7 days, and the chemopot can be kept in place for 3600 pricks or more than 5 years. Parts of central catheters. Here, there is a hollow soft tube that may be separated into 2 or 3 individual channels called lumen. The tube can be single lumen, double lumen, and also have triple lumen catheters. And a screw-like adapter on the end of the lumen called as cap that helps in decrease microbial growth and risk of catheter-related bloodstream infection. Here we have a plastic clamp on the lumen to close the catheter when not in use. This is an junction hub which is used to stabilize the catheter using a suture. Indications: to measure central venous pressure, for the insertion of pulmonary artery catheter, and for the administration of intravenous therapeutic agents and nutrients for the long period of time, and for the performance of hemodialysis, for the placement of cardiac pacemakers. This procedure is also used in other situations in which to directly access to the central circulation if needed. The other situations like emergency situations. The general contraindications of central line catheterization are infection of the placement site. It tells that if there is any infection near to the insertion site, which may allow the infection to enter the central circulation. Suspected pathological conditions affecting internal jugular vein or subclavian vein, and also contraindicated in superior vena cava syndrome. If there is occlusion due to coagulopathy, caution should be used when the landmarks are not seen by trauma, like burn injuries. Other anatomical anomalies such as goiter. Be careful when using this.
Prior to the insertion procedure, the preparation of client and equipment has to be done. Open central line kit on the bedside table and position it within easy reach. Before unpacking the kit, put on face mask, surgical cap and gown. Take sterile draping from the kit, which will be helpful to arrange the content on the table in the order. Equipments used for CVC insertion. A chlorhexidine antiseptic applicator or can be used betadine or iodine solution. A sterile drape or trolley sheet to maintain sterile area. 1% lidocaine and 3 ml syringe with the 25 gauge needle for local anesthesia. Several 5 ml non-Lurolox syringe which will be used for aspiration during insertion. A variety of needle includes 22 gauge 1.5 inch finder needle that is used as a finder needle and also for administration of local anesthesia, and also 18 gauge 2.5 inch introducer needle that is used to cannulate the vein. A guide wire housed in a plastic assembly which is required for the insertion technique. Note that the guide wire is called J wire. It allows the wire to bounce off the vessel walls to reduce the risk of perforation. Note that the guide wire housed in the straightener sleeves that facilitate the insertion of the wire into the needle hub. A 11 number scalpel blade which is used to make a nip in the skin to allow passage of catheter into the vessel, and a dilator which is used to create a track into the subcutaneous tissue or the catheter. Central line catheter which is triple lumen catheter, which may be in the several size and lumen based on patient condition. Sheath introducer, which is used instead of double lumen and triple lumen catheter, which is larger in size. Finally, your central line kit includes suture material used to secure device to patient and sterile gauze to clear excess blood over the patient's site.
Use the 3 milliliter syringe and the 25 gauge 1-inch needle to place a wheel of anesthetic in the skin. Switch to the 22 gauge 1 1/2 inch needle to place anesthetic into the deeper tissues. Next, attach a 5 milliliter syringe to the 18 gauge 2 1/2 inch introducer needle and advance toward the vessel. Pull back on the plunger as you proceed. Blood will fill the syringe when the vessel is entered. Carefully remove the syringe from the needle, insert the guide wire assembly into the hub, and advance the guide wire into the vessel. Once approximately 15 centimeters of wire have been advanced into the patient, remove the plastic housing, leaving the guide wire in place. You may now remove the needle so that just the guide wire remains in the vessel. Use the 11-blade scalpel to create a small nick in the skin around the guide wire to facilitate passage of the dilator and the catheter. Carefully advance the dilator over the wire and into the subcutaneous tissues with a slight rotating motion, and then remove it. Next, advance the triple lumen catheter over the wire and into the vessel. Finally, remove the guide wire from the catheter and place the end cap over the exposed port. If using a sheath introducer instead of a triple lumen catheter, the technique is slightly different. Fully insert the dilator into the introducer prior to the procedure. Once the guide wire has been placed, insert the dilator and the introducer as a unit into the vessel. Once fully inserted, the dilator and the wire may be removed together.
As a nurse, we play a direct role in care and maintenance of patients' healthcare. It's our responsibility to keep up our promise and to do no harm to our patients. One area of concern shared by many hospitals, that is care and maintenance of central lines. Central line associated bloodstream infection or CLABSI are severe and potential life-threatening condition for the patient. Following nursing care helps in preventing CLABSI, are also called central line associated bloodstream infection, can be prevented. Today we see how to prevent infection and maintain properly functioning line.
The 3 components you have to go through for the care of the central venous catheter, or CVL, are hand washing, changing of dressing, and flushing. Before handling the catheter, it is important to keep your hands clean. These are the steps you should follow for proper hand wash. Wet hands and wrist. Apply soap, palm to palm. Right palm over left, then left over right. Fingers interlaced. Back fingers to opposing fingers interlocked. Rotate rubbing of both thumbs. Rub fingertops. After your hands are clean, Pat dry with a clean towel. Changing of dressing. The 4 steps of changing of dressings are preparations, removal of dressing, cleaning of the site, and putting on new dressing. The central venous catheter, or CVL, is a soft hollow tube placed into a large vein leading to the heart. The tube comes out from a small opening at the chest, known as the exit site. Proper care for the CVL is important in minimizing problems and infections at the site. Prepare your items on a tabletop. Ensure that your tabletop is clean before you place any items on it. The items you will need for changing the dressing are chlorhexidine lotion, CHG. If CHG is not available, you may replace it with povidone iodine swab stick, dressing pad, micropore tape, and alcohol swab.
First step of changing the dressing is removal of old dressing. First, before doing the dressing, you have to arrange all the articles within an easy reach. Do hand washing. Wear clean gloves. Wear mask on you and your patient. Gently remove the old dressing. Discard the old dressing and check for any redness, swelling or discharge from the exit side. Ensure that stitches are intact. Remove the gloves and wash your hands. Apply sterile gloves. Take a sterile whole towel and cover around the insertion site and catheter. Take a sterile cotton ball, apply betadine or chlorhexidine solution and clean the exit site and around from center to periphery. Take alcohol swab and clean the exit site until it is clean and allow it to dry. Take another piece of alcohol swab and clean the catheter tube till the tip of the catheter. Check for the suture. If the sutures are not stable, take a blade and remove the stitch and ensure that all the stitches are removed. Take a skin protectant and apply under the junction hub over the skin. Take a stat-lock device and see that the device is attached properly to the junction hub and the skin. Keep a sterile gauze piece to the exit site and over a stat lock. Take a transparent dressing and cover entire catheter and the exit site with a transparent dressing. Remove the outer covering and see that the dressing is attached properly to the skin. If you are using Tegaderm dressing, which is called transparent dressing, it should be changed every 5 to 7 days and whenever necessary. If you are using gauze and tape dressing, change dressing every 48 hours. And finally, label with date and time.
Here are some of the frequently asked questions. What are the signs of an infection? Swelling, redness, or unusual discharges from the catheter exit site, accompanied with pain and fever, are signs of an infection. Inform a doctor immediately if you face these symptoms. How often should the dressing be changed? The dressing should be changed once to twice a week. What if my dressing becomes loose or dirty before the due date for changing? Change the dressing immediately. What if my stitches are loose? If it happens during clinic operational hours, please call the clinic for assistance. If it happens after clinic operational hours, for one stitch, just secure it with dressing tape and return to the clinic the following day for restitching. For 2 stitches, please proceed to the nearest hospital for restitching immediately.
Care of implanted port. Supplies you will need are clean and sterile gloves, alcohol swab, 2 pair of masks, a tape, 10 ml of normal saline, a non-core needle, dressing set, 2 pair of syringe 10 ml and whole towel, COVID in solution, surgical spirit, and finally heparin lock. Arrange all the articles on the table. Wash your hands and apply clean gloves. Wear mask on you and your patient. Again wash your hands and apply sterile gloves. Take a whole towel and cover the exit site or the chemopot site. Locate the chemopot with your hands and clean the area with betadine swab or chlorhexidine solution from center to the periphery. Take alcohol swab and clean the area from center to periphery until it is clean and allow it to dry. Take an encore needle, flush the needle with normal saline to push out the air. Remove the clamp area towards the tube and clamp the tube. In one hand, stabilize the port with index finger and the thumb. With the other hand, take a needle perpendicular with a 90° to the skin. Insert the non-core needle through the skin and into the center of the portal septum with the bevel. Pushing until it feels the needle stops at the back of the portal chamber. Pull back the syringe to access for the blood return and verify the placement. Now the blood is returned. Here you can see the blood return. This confirms that the needle is in the chamber. Flush the lumen with the 10 ml of normal saline. To clear the chemopot chamber, take a 3 ml of heparin solution in 10 ml of syringe and flush the lumen to maintain patency of the chemopot. Before flushing, you have to check for the clamp is unclamped. Clamp the line, remove the syringe, recap the tube, now cover the chemopot needle site with the gauze and the tip of the chemopot needle and cover it with a gauze and tape. Cover the needle site with a transparent dressing which is called tegaderm, where you will use a small dressing for the chemopot. Remove the outer wrapper and secure the dressing toward the skin. Now the dressing is complete. Check that there is no discharge. Clamp is done. And now remove the drape and discard it. Attach the tube to the skin with a small plaster. This completes the chemopot. Now removal of chemopot needle. Remove the old dressing carefully. The removal of dressing or the removal of chemopot needle is done once the chemopot is not necessary for the patient. But the chemopot will be in the place under the skin. We are just removing the needle of the chemopot. This needle, once it completes the cycle of treatment for the patient, the needle will be removed, or every 5 to 7 days the needle will be changed. Take a cotton ball and hold the needle and remove the needle. Apply pressure over the site for a few seconds to stop the bleeding, and this completes the dressing. You can send the complications of central line dressing. Central line cannulation is an invasive procedure that can result in infection commonly called as central line associated bloodstream infection, also called CLUPSI. They cause a greater deal of morbidity and death. If central line infection is suspected in a person, blood culture are done. Air embolism, which is caused due to an uncapped tubing. It can be treated with an Trendelenburg position and death. Complications occurs due to mechanical injury, carotid artery puncture, and also an skin hematoma. Next, there will be a pneumothorax. Pneumothorax incidence is higher with subclavian vein catheterization. The symptom of pneumothorax can be relieved with the Fowler's position. Hemothorax and misplacement of catheter is more common when the anatomy of the person is different, or complications of central line dressing. Central line cannulation is an invasive procedure that can result in infection commonly called as central line associated bloodstream infection, also called CLUPSI. They cause a greater deal of morbidity and death. If central line infection is suspected in a person, blood culture are done. Air embolism, which is caused due to an uncapped tubing. It can be treated with an Trendelenburg position and death. Complications occurs due to mechanical injury, carotid artery puncture, and also an skin hematoma. Next, there will be a pneumothorax. Pneumothorax incidence is higher with subclavian vein catheterization. The symptom of pneumothorax can be relieved with the Fowler's position. Hemothorax and misplacement of catheter is more common when the anatomy of the person is different, or central venous access device is commonly performed procedure that can be life-saving but also associated with significant complication. As a nurse, we should have a very major responsibility in care and maintenance of central line catheter care, and also in minimizing the complications. This video has been covered with 3 major components of central line catheter care are hand washing, dressing and flushing. I hope this video will be helpful for all nurses in handling the patient with central line catheter with your self-confidence and courage. Thank you all.
The 3 steps of flushing are preparation, changing the cap, and flushing of the CVL. To ensure that your catheters are clean, They should be flushed once a week or as instructed by your doctor. Before you handle the catheter, be sure to wash your hands thoroughly. Ensure your tabletop is clean before placing items on it. The items you will need are 5 ml syringe with attached needle, 5 ml heparin saline, 2 pieces of alcohol swabs, a packet of sterile gauze, and micropore tape.
First step of flushing is cleaning the hub of the catheter called cap. Take alcohol swab and hold the catheter tip with your one hand, and with the other hand clean the tip using alcohol swab in far and back motion or turning motion. Each lumen tip has to be cleaned with separate alcohol swab. If you are changing a new cap, clean the tip of the catheter and apply a sterile new cap to it. Flushing the line. Take a 10 ml syringe, load the heparin solution or sodium chloride. Each lumen should be flushed with 3 ml of heparin solution. Remove air from the syringe. Then remove the needle from the syringe. Attach the syringe to the catheter tip. See that it is secured in place. Make sure that the clamps are unclamped. Holding the syringe in your one hand and place the thumb on plunger and slowly push the fluid into the line with an push-pause technique. If we feel the resistance, check for the clamp is open. If still the resistance exists, do not continue flushing. Check for blood return. If there is a clots during blood return, that a 10 ml of saline and push the fluid into a push-pause method, and finally push a heparin solution of 5 ml and close the clamp and remove the syringe and recap. Do this for each line. If there is no backflow and have more resistance, that indicates the line is not in the vein or blocked. So stop pushing and saline, and also call for doctor. Cover the catheter hub with an sterile gauze and a tape. Remove the drape over the catheter. This technique of changing the dressing cap and flushing the line is done for all the catheter line, tunneled, non-tunneled, PICC line, and also all types of single lumen, double lumen and triple lumen catheters.
Are some of the frequently asked questions. Where do I store my heparin saline? Store heparin saline in room temperature.
Include: what if I have difficulty flushing the line? If you or your caregiver are unable to flush the line and the line has a clamp, first make sure that it is unclamped. If you are still unable to flush the line, call your healthcare team. Do not try to forcefully flush the line if you meet resistance. What if I experience chills? If you experience chills when flushing the line, call your healthcare team immediately. This could be a sign of infection. What if I drop my syringe? If you drop your syringe, throw it away and use a new syringe.
Removal of PICC or central line. The supplies you will need are 2 face masks, a clean paid gloves and a sterile paid gloves, a suture removal kit if applicable, sterile gauze and triple antibiotic ointment, a transparent dressing large enough to cover the gauze, and extra tape as needed. And for the PICC, you will need a tourniquet in case of emergency. Apply mask to you and your patient. Wash your hands and apply clean gloves. Open the suture removal kit if line is sutured. Prepare a sterile gauze dressing by placing triple antibiotic ointment on it. This will be the dressing applied to the exit wound site once the line is removed. Place patient in supine position with the head of the bed flat and have patient turn his head away from the catheter. Remove dressing and start lock. Remove gloves, wash your hands and apply sterile gloves. Cut the sutures and pull them through the skin, being sure to remove all the suture material. Instruct patient to take a deep breath and hold it in. Slowly withdraw the catheter in one continuous motion and with the other hand quickly apply pressure over the insertion site with a sterile gauze that has a ointment applied. Please note, if resistance is met, pause momentarily and retry. If resistance is still felt and arm is in the swollen, try to massage arm and apply warm compression and try to remove later. If resistance is still noted, stop and notify medical doctor. Patient catheter is out. Immediately cover with an occlusive dressing by placing the sterile gauze with the ointment on the wound site to create a seal of ointment to prevent air embolism, and then cover the gauze dressing with transparent dressing. Secure with tape. Maintain pressure for 2 to 5 minutes until hemostasis has been achieved.